Thank you, Chairman, for the introduction. Good afternoon, ladies and gentlemen. So this is the second talk for me. And in the coming 15 minutes, I'm going to talk about the adherence with therapy and also the management of side effects. Oops, let me see. It's working. So I think we have previous talk about, the latest CML treatment, and we now know, and I think we all agree that we have very effective therapies, and that give rise to very effective disease management. We can achieve, MMR, CMR. But the problem is, to achieve this sort of effective disease management, we actually need the patients to take the drugs. Adherence to medication is actually the link between a good drug and also a good treatment outcome. And as illustrated by one of our former U.S. Surgeon General, drugs don't work in patients who do not take them. I think this is absolutely true. And the problem is adherence or compliance to TKI a problem in patients with CML? Well, nowadays we treat CML like, a chronic disease. And like other chronic disease, hypertension, diabetes, anything you can name, compliance or adherence is always a problem. We do have quite extensive data from imatinib that about 1/3 of the patients taking the drug is actually not adherence, in the sense that they took the drug less than 90% of the prescribed dose. For Dasatinib and Nilotinib, we have got a little bit less data, but at least from my personal perspective, I do believe that adherence can be a problem even with the second generation tyrosine kinase inhibitors. Now, continuous effective dosing is important for optimal outcomes. I think this is a very, very important message. And in fact, non-adherence to dose requirement may result in a lack of optimal response or suboptimal response, and also increased risk of relapse or disease progression or treatment resistance, as well as additional healthcare costs due to poor health. So this is a study published a few years back, and illustrating that poor adherence can actually increase the risk of suboptimal response. You can see that for those patients who achieve an optimal response, and on average they take about the non-compliance is about only 7.3 of the tablets of the imatinib. But if you look at the suboptimal response group, then probably the group actually took maybe about 1/4 less than what has been prescribed. And this is also similar if you talk about the complete synergetic response versus no complete synergetic response. For those patients who didn't achieve a complete synergetic response, you can see that compliance is an issue. In another study, which is probably, again, about 3 years back, you can see that if you talk about the 6-year probability of MMR and CMR, according to the measured adherence rate, you can see that for those patients who got an adherence more than 90%, they have probably a chance of achieving a major molecular response about more than 90%. Compared with those, if they got just adherence less than 90%, you can see that the rate of achieving MMR is significantly lower to less than 20%. So you can see by having a sort of a patient adherent to the treatment actually makes a big difference compared with the drug that you choose to use. And the same is also seen in CMR. You can see that those patients who are adherent has got a much higher chance of achieving a complete molecular response, which nowadays we call it MR4 or 4.5 or even 5. And also, poor adherence is not only associated with failure to achieve optimal response, but it's also associated with loss of complete synergetic response and also lower event-free survival, as shown in this study, you can see that those patients who have got the adherence rate below 85% has got a much higher chance of develop failure or loss of CCYR, as well as the probability of imatinib failure. So we all understand that the drug is very expensive, so some patients may want to save some costs by, reducing the dose or, even stop taking the drugs. But the problem is, although we save the drug cost, it may actually increase, the healthcare resources that we need to take care of this patient. And there are multiple studies showing that those patients who are not adherent to the treatment because, of all the adverse outcomes that I've shown you, they require more inpatient visits. They require to stay in the hospital for a longer time. So at the end, the healthcare cost is actually increased. So what are the factors affecting the patient's adherence to therapy? Now, of course, adherence is a complex issue. So there are many factors which can affect the patient's adherence. So patient's characteristics is certainly one of the important factors. I'm sure that we have all encountered patients who are born to be non-adherent. They just don't listen to anything. And of course, the lifestyle of the patients as well as the regimen is also important. I'm going to talk about the adverse effect a little bit later. Okay. Oh, so this is not the latest version. Did you update it? This is not the latest one. So there a few slides were missing. I'm sorry, but basically, I think just to mention a few things about all these sort of factors. I think there are certainly some patients' factors which are not predicting non-adherence. For example, those younger patients, those who live alone, and those patients who got poor memory. Obviously, we got a problem. And for the regimen issues, I think most of the patients, at least to me in my centers, they prefer taking drugs who can be taken once daily rather than multiple doses per day. So sometimes it's also related to the lifestyle, whether they can follow the regimen. So I think this is very important that we should address all these issues. And the most important things when I try to increase the adherence of the patient is actually to provide the patients adequate education and counseling, and so that they understand the disease well. And there's been many data showing that for those patients who understand the disease better, they tend to be more compliant, okay? And the disease control, the outcome will be better. So at least to me, I spend quite a lot of time in educating the patients, telling them about what is CML, what treatment they need to receive, and potential side effects, as well as the regimen, and so that they can comply with the treatment. And of course, also in my center, whenever, because nowadays we have got 3 drugs, okay, which we can actually use, I always discuss with them the right drug to choose, and so that they actually, I explain to them the different regimen, the side effects, so that they can participate in making the choice. And of course, I also invite the families and other people to actually try to help them to ensure the compliance. Perhaps in the second part of my talk, I'm going to focus about adverse event, which is actually a very important part in our CML management, as well as ensuring the compliance. Now, I think adverse event is actually a major hurdle to the compliance of the patient. Now, we have been using imatinib for a long, long time. I think we have a lot more experience with them. And in fact, about more than 90% of the chronic phase CML patients treated with imatinib have actually got some form of experienced some form of adverse event. So it's important actually to identify these sort of adverse events, provide them the appropriate management so that the patients are willing to take these drugs. But of course, I should have actually put another box here that we have to not actually only to identify and manage the patient, but we should actually proactively educate our patients, and so that they can anticipate, they understand that there will be some side effects. In fact, I always tell my patients, okay, you will expect some form of side effect because this is the price to pay for an effective treatment. And I think we have all experience of using imatinib, and in fact, at least for imatinib, okay, some form of this sort of non-hematological side effects is actually quite common, such as the GI upset, the musculoskeletal problem, and also the edema are actually pretty common. But most of these are actually manageable, and patients can actually continue to take the drug as long as we can adequately manage this sort of adverse event. Now we have 3 TKIs widely available, and for the management of CML. The good things about having 3 choices is that not only we have the second generation which are more potent, but also they also have different sort of side adverse event profile. For example, as I've discussed, imatinib usually causes a lot more edema and musculoskeletal problems, some GI upset. For the Nilotinib, the major problem is probably with the pancreatitis, the lipase, amylase, the liver, and maybe the glucose as well. On the other hand, for Dasatinib, okay, the most important ones will probably be the pleural effusion. But there's also always something common to all of them, is actually the hematological toxicity. So that's why I always tell my patient before I start them on any one of the TKI that we probably will expect some form of anemia or thrombocytopenia, neutropenia, and so we have to monitor them at least very closely during the initial phase or the first 1 to 2 months of treatment, and of course, adjust the dose appropriately. For example, this is a recommendation for the Nilotinib, so that we may have to hold the dose for a while, or we may have to cut down the dose. On the other hand, there may be some patients who develop some form of cytopenia later after the treatment, and in that case, we have to worry about possibility of resistance or relapse. For the Nilotinib, I think one of the very common side effects is actually skin rash or pruritus. I always tell my patients that trust me, you're going to get a rash. Okay, the problem is how severe it will be and how much problem you'll get. But the only things, another important message I always tell my patients is that don't panic. This is not drug allergy. You can continue the drug because most of these sort of skin rash are actually self-limiting and they can resolve by themselves. But of course, I always tell them that if the rash is getting severe, you're getting a lot of problems, come back to see me. I'm going to give you something. Most of the time, this rash will settle with just some antihistamine. I haven't got any patients who actually require systemic steroid, but that can be a choice in case of very severe problem. For other problems with Nilotinib, such as the liver problems, amylase elevation, the lipase elevation, depends on the clinical situation. You may monitor that, but in severe cases, you may have to hold the treatment and then later on to restart maybe at a lower dose when the symptom when the problem actually resolved. This is the same with bilirubin problems. Similarly, for Dasatinib, okay, this is a recommendation, again, for patients who have got neutropenia from cytopenia. Again, if the patient has got a severe sort of cytopenia, you may have to hold the dose, and if it recurs, or if the cytopenia is really severe, you may have to cut down the dose. Again, I always educate the patients that this is something we expect, so we don't need to panic. Pleural effusion, again, is a characteristic problem of Dasatinib, and I always maintain an awareness of the symptom and actually get a chest X-ray whenever the patient has got any symptoms suspicious of pleural effusion. And again, for those patients who have got grade 3 or grade 4, we may have to give them some treatment such as diuretics, steroid, and dose interruption. But most of my patients actually can respond to this sort of supportive treatment, and they can restart on the treatment and maintain on it. For the other relatively minor adverse events such as rash, headache, GI upset, and diarrhea, most of the time this can be managed with just supportive care, symptomatic treatment, and the patients can continue to receive the drug. So I think it's important that we identify these sort of adverse events early, manage them appropriately so that we don't affect the patient's quality of life and facilitate them to continue the treatment at an appropriate dose. So we always try to maintain the optimal dose and manage the side effects appropriately. So I think in summary, non-adherence to medications regimens actually impacts the clinical benefit and can result in increased healthcare costs. This is also the case in patients with CML. And ensure patients' compliance to TKI therapy is crucial to better outcomes in patients with CML. Multiple factors, including the side effects, actually contribute to non-adherence. And at least for adverse event, I think patient education, prompt identification, and appropriate management are important to ensure patients comply. This is the end of my presentation. Thank you very much for your attention. I'm happy to take your comments later.